What is the common age where type 1 diabetes present?
More commonly, it is below 20 years. It is also genetic.
People are dying very young.
People in their 30s, early 30s, they are undergoing.
Example of Tyagaraja Bhagavat. So, as you know, he's a legend. But he has a long-standing history of diabetes that you may not know. At the time of death, he was blind. This is a true story. My patient told me that my AC is high, my AC is high. I said, what is the problem? Doc, call an electrician. Then he said, A1C.
Lifestyle, how to be relatively stress-free. Of course, nobody can be stress-free in this world.
There can be only sugar-free in the drinks. Brown sugar versus white sugar.
I don't think there is any big difference in them. They are all glucose at the end of the day.
See, next time you eat idli and then you see your glucose spike and then you say don't eat idli, Gutman is watching.
Don't eat anything for 24 hours and then the next day only they eat. That won't work for diabetics.
Yeah, I have the same concept as well. A patient came into me in my clinic and then he had Diet Coke right in front of him. I said, let's say a 40-year-old gets diagnosed with diabetes and he's concerned that, will I pass on to this my kids?
Type 1.
Social drinking, will that have any effect on diabetes?
Drinking every day.
Before we dive in, can I be honest with you? It blows my mind that 57.9% of you who listen regularly still have not subscribed to our channel. If you enjoy the podcast, the stories, the science, maybe even laugh at our jokes, could you do us a small favor? Hit that subscribe button. It takes only 2 seconds and helps us keep bringing you better guests and episodes every week. I'm truly blessed to have all your support and I'm sure you will support me in the journey. Now, let's get into today's episode. Hello guys, this is Dr. Pal Manikam. Welcome to another episode of our podcast series, Gut Feeling with Dr. Pal. I'm liking to enjoy this podcast series a lot because I am learning a lot by interacting with other medical doctors. Today we have Dr. Kumar, who is an endocrinologist in Kaveri Hospital here in Chennai, and he has had close to 20 years of experience in treating diabetes patients. Because diabetes, pre-diabetes has been one of the major point of discussion in our channel, we thought it would be a wonderful idea to interview him and then talk about all the things about diabetes. So we talked about how to diagnose diabetes, how to treat diabetes. If you are a diabetic patient, what should you do to prevent any complications? How should you know about what are the complications? And we talked about glucose levels, the diet involved, exercise, sleep, what kind of exercise, when you should see a sleep specialist. So if you are someone who has a family member with diabetes, or if you are someone recently diagnosed with pre-diabetes, or if you are someone who wants to prevent diabetes to happen to you, this is a wonderful episode. I learned a lot as well. I'm sure you will as well. Let's dive deep into it. Hi, Dr. Kumar. Thank you so much for being in my podcast. I am so excited for this episode.
Hello, Dr. Pal. I am glad to be here as well.
That's so nice of you. So nice of you. You are MBBS here, Chennai, Akil Park, MD, General Medicine, and then you went to UK. You did specialized in endocrinology. Yes. You came back to Tamil Nadu, and then you started practicing endocrinology for the last 10 years.
Yes, correct.
First of all, kudos to coming back.
Thank you.
Not many people do that, including me. I'm thinking about, but you're inspiring people like us.
Thank you.
And so the main thing that we wanted to have you on the channel is that we wanted to talk a lot about endocrinology, multiple diseases, because we talk a lot about gut health, and I strongly believe that gut health is very positively associated with multiple hormones.
True.
One of the most important hormones is insulin.
Yes.
Insulin. So we thought that this episode will be just focused on diabetes alone, and we'll be bringing you back sometime later for other diseases.
Sure.
Okay.
Certainly.
So how long have you been practicing in Kaveri Hospital now?
And now it's close to 2 years now in this branch of Kaveri.
In this branch of Kaveri, okay. On a given day, how many patients you see?
In outpatients clinic, close to 25.
25.
Patients
Okay, super. Yeah. And I just wanted to ask you, from a layman standpoint, if I have to zoom in and then tell what is happening with diabetes inside the body, with insulin, the cells, and the glucose level, what will you say?
Okay, so what's happening inside the body? Okay, fine. So in diabetes patients, I guess you're asking about. Okay. So, the diabetes is a condition where predominantly there is insulin resistance in majority of the patients. In the initial stages, a lot of insulin is secreted to overcome this resistance, and these people are typically overweight.
What is insulin resistance? So there's a lot of insulin, but it is not working. Is that what insulin is?
Yeah, exactly. The obesity is the main culprit behind this, and the obesity prevents this available insulin from being effective. So and as a result, the pancreas tries to overcome this and secretes more and more insulin, thinking it can overcome this. So and as a result, more insulin, more weight, this goes like a vicious cycle.
So let me summarize that for you. So people are lean initially and they are getting slowly bigger. When they are getting bigger, the existing insulin does not work well.
Correct. Yeah.
So the glucose level goes up.
Yes. Correct.
So then the body thinks that, hey, glucose level is going up. Let's stimulate the pancreas to secrete more insulin.
Yes, exactly.
So in diabetes, especially in type 2, it is not about lack of insulin. That's people think that you give insulin because you don't have insulin.
Exactly.
That is not true. Correct?
That's not true, except in the late stages, like somebody is 30 years diabetic, type 2 diabetic. They may not have adequate insulin reserve because all the way we have given a lot of tablets to stimulate insulin release and back and back and back. And so at that point of time, they get a bit exhausted and they need insulin supplementation. At that point of time. Till that point, it is mostly insulin resistance, and that's where we have to focus.
You have to focus, yeah. One will have like 10 to 15% chance based on whether father or mother are diabetic or something like that, based on what you told me. 5 to 15% chance. Type 2, it's because of multiple chromosomes are involved. The likelihood of them developing might be speculatively slightly higher.
Probably.
Possibly.
Yes.
Probably. We may not have a particular person. So is it fair to say that mom or dad is being diagnosed with pre-diabetes or diabetes, they should take extreme care on their kids, not only in terms of diet, but other lifestyle changes so we don't pass on them to them?
Yes, exactly. Exactly. Though the genetics are there are modifiable factors. Exactly what you said, like how they are bringing them up, and the lifestyle, what they give them to eat. How do they make them exercise, teach them the importance of being active around, teaching them lifestyle, how to be relatively stress-free. Of course, nobody can be stress-free in this world, especially the children.
They can be only sugar-free in the drinks, not stress-free.
Yeah, absolutely. At least that, if they can take care, obviously we can postpone the genetics as well.
That's a wonderful point. So I remember reading about this. There's a non-modifiable risk factor, modifiable risk factor.
Yeah.
Non-modifiable is your genetics. You can't do anything about it. But modifiable is if you are diagnosed with diabetes, if you want to prevent them to pass on to the next generation, you focus on their lifestyle so that they will never get diabetes as much as possible.
Okay, I would probably remove the word never, but probably they can avoid or postpone.
Is that how the presentation is even now?
Not really, I would say. Yeah, many times they are asymptomatic. Their relative or a spouse is a diabetic and they just want to check their level as well, just as a playfully, and they find it to be 550, 450 like that.
Wow.
And then they come next day or come running after seeing the numbers. So it can be completely asymptomatic as well.
Wow. Is that type 1 or type 2?
No, this is more about type 2. Type 2.
Type 2. How do type 1 present?
Type 1 presents many times when the patient is under stress, like they're going for surgery or they get a fever or infection. Some sort of stress precipitates and brings it out. The diabetic ketoacidosis, which is a life-threatening condition, is a very one of the common presentations for type 1 diabetes. Of course, the other features, like as you mentioned earlier, the progressive weight loss, passing lots of urine, those kinds of presentation can be typically with type 1 diabetes.
So type 1 will actually lose weight.
Yes, exactly.
But type 2 will actually...
To begin with,
they
will be
gain
overweight or keeping on going weight unless it becomes out of control and they then lose some 5-6 kilos suddenly and then they come running to check their sugar levels.
Wow, yeah. Wow. Tell me a case scenario where you have been surprised, can diabetes be present in this way at all?
Balanitis, that is the infection of the foreskin of the penis in men, which is happening to be in South India, a very common presentation. And nowadays, somebody complains of balanitis, immediately I almost conclude they are diabetic, and it's quite closely associated.
So balanitis is infection of the foreskin of the penis.
Foreskin of the penis, yeah. If that happens, then that should ring a bell. Because it's very common nowadays.
How do they present? Discharge?
They present with itching in the front part of the penis, sometimes burning, rashes, That kind of presentations usually.
And then you check glucose levels, it's high.
Yeah, invariably almost, I would say.
Interesting.
Yeah.
Nice. Okay. All right. So now the most common condition that people always see is pre-diabetes.
Yes.
Okay. And it is a very common term that's being like loosely used in the IT world.
Yes.
Where they get the annual blood checkup and they say, oh, I'm pre-diabetic. Yeah. Nowadays it has become a fashion. I'm a pre-diabetic. How about yourself? Please specify about the fasting, because all my friends are just eating at 3 a.m. and then taking the blood glucose at 7 a.m.
There should be at least 8 hours of complete fasting. They can drink water in between, obviously, but otherwise nothing for at least 8 hours for sugars.
So
that
somebody,
should be enough for a fast.
So somebody check their glucose levels in the morning, and if it is more than 100, less than 126, then they are pre-diabetic.
Pre-diabetic, but they should also do a proper test like a glucose tolerance test. And in the second hour after glucose drinking, if it is below 140, it is normal. But 140 to 199 is said to be pre-diabetic as well. 200 or more than 200 is diabetes.
Have you seen patients where the fasting is in the pre-diabetic range, but in the postprandial it has become normal?
But yeah, we do see that as well. But they are also pre-diabetic.
Pre-diabetic.
Yeah.
Pre-diabetic.
Not only that, the HbA1c should be less than 5.6. So 5.7 up to 6.4 HbA1c is also pre-diabetic. Independently. Yeah, even if their GTT is totally normal, glucose tolerance is normal, HbA1c is like this, then they should also be taken as a pre-diabetic.
Are you serious? So if a fasting glucose is normal, but the A1C is around 6, then it is still pre-diabetic?
Yes.
Okay. Sir, based on what you're telling me, so if I'm watching this podcast, I am concerned that, okay, I may have diabetes. So then what age then we should check for blood glucose levels?
About 35 years, it is better to check for diabetes, especially if somebody has got a strong family history, like parents or siblings having diabetes, or if they have any medical conditions, hypertension, or if they are having a poor lifestyle, being obese, or on long-term medications for long-term conditions, or medications that can produce diabetes like steroids and other medications. So that sort of group of people should get themselves checked for diabetes. Or somebody has had pre-diabetes already in some checkup, it's better to follow up very closely. Especially in women, those who have had gestational diabetes. After the childbirth, they do check once and they are all clear. Majority of them, they just forget about it. They have to actually every 3 years go about doing.
So you're saying that a patient with gestational diabetes during pregnancy increases the risk of diabetes throughout?
In future, as age goes, the risk also goes further up and up. So at least every 3 years they should get a glucose tolerance test and get properly checked for diabetes.
How about a normal person? They check blood glucose now, it's good. When should they repeat it again?
Like every 3 years.
Every 3 years?
3 to 5 years, depending on the risk category.
What is the choice of the test? Fasting blood glucose or A1C or both?
Preferably both. Because the criteria, even independent abnormality, fasting or postprandial or A1C, qualifies for pre-diabetes or diabetes. So in that case, it's better to check all the three, because they're going to do only once in 3 to 5 years. It's better to do a proper 75-gram glucose tolerance test and HbA1c also, to make sure they are on the clean side.
Oh, so you are recommending all three?
All three, because we don't do frequently, because if we miss one criteria, then we may be missing the diagnosis. So it's better to do everything.
Okay. My patient, this is a true story, my patient told me that my AC is high. I said, what is the problem? Doc, call an electrician. Then he said, A1C. A1C is high. So you said that you check A1C level once in 3 years. And if it is between 5.7 to 6.4, you're pre-diabetic.
Annually, better to check annually in future.
If you fall in that category, then you check every year.
High risk category, then you go on checking every year.
Okay, super. So we talked about diagnosing diabetes. Let's say we diagnose with pre-diabetes. Okay, I have A1C of 6.1. How often I should check the fasting blood glucose at home?
They don't really need checking at home unless they are on treatment. There is no need. But 3 months down the line, they can check one value in the lab itself, and that should be enough. No need for checking at home.
Checking at home. How about if they are like diabetic on medications?
Oh, okay. Right. It all depends how uncontrolled, how fluctuating the sugar levels are. If they are very unstable, then they may need frequent testing. Once settled, then the frequency can come down. So it's difficult to put a number. If somebody's on 4 times insulin a day, they may, to begin with, they may check like 4 times a day. Or even more sometimes, and they may need a continuous glucose monitor also sometimes. But when they get settled with a particular dose and diet regime, and they are stable without wild fluctuations, they may need less and less testing. If their food or activity or anything goes up or down, they may have to check and administer the medications accordingly. But if routine is going on, then they may not need frequent checking.
Any most common mistake that people do with the glucometer testing that in your experience?
All right, yeah, okay. So they don't really wash their hands and clean it properly before checking. If they've handled the food stuff, then that may reflect badly in the glucose levels. So they can also make sure they wash their hands and check it properly and at the right timings. They make sure the glucometer is properly calibrated.
In social media, everybody is using this continuous glucose monitoring right on their arm, and then they eat all these normal foods and then say the glucose is spiking, so don't eat this food even for normal people. So question to you is, do normal people need this CGM?
I wouldn't say so. No, CGM we use for only special situations. When the blood glucose is tumultuous, like up and down, you're not able to predict what causes the increase or the decrease and what happens in the middle of the night. All these things are not clear. Then the CGM will be really useful. But it should not be also, it's a privilege which should not be abused in my opinion. Not for normal people and go on checking if I eat 2 sweets, how much is going up. And obviously the sugar will go up in normal people, and that will be countered effectively by the insulin released. And so if their blood tests, which we said yearly or annual checkups are normal, they don't have to worry about checking with a continuous glucose monitoring. They should.
Thank you so much, sir. This is one of the most important things. See, next time you eat idli and then you see your glucose spike and then you say don't eat idli, gut man is watching. So the glucose spike is normal where your insulin quality is so good that it will be able to control you. So that's a normal physiological mechanism.
Absolutely.
But that doesn't happen in diabetic patients.
Exactly.
For them, CGM makes sense.
Yes.
Wonderful. So thank you so much. So now we talked about all the treatment options and everything. I'm going to talk about the biggest elephant in the room, which is insulin. Okay. People are so scared to go on insulin.
Okay, it also depends on the clinical scenario. Not like one size fits everyone. But generally speaking, if the hemoglobin A1C is 10 or above, they are diabetic for quite some time, not just diagnosed diabetics, and then they may need insulin. In other terms, also the other factors like a catabolic, like if they are losing weight because of poorly controlled diabetes, they are the ones who likely will benefit from insulin. And also uncontrolled, very much like about 300 milligrams per deciliter glucose levels, and they are already on medications and not really getting controlled or better, then we may consider insulin, provided we have addressed other factors also, like their lifestyle. Have we addressed their weight? Because more and more insulin will be met with more and more resistance in obese people. But without addressing that primary problem, if we just pump in insulin, it may not be working as well, except the side effects.
That was my next question. How many percent of people in your practice takes insulin but do not change their diet?
Okay. I wouldn't be able to say a percentage.
Or on average, so let's say 100 people come to you. You see so many patients. Will you say, like, what is the awareness out there in the public where the disease control is mainly because of diet and not because of medications alone? That's why. So you'll say like 5 to 10% of the people?
Probably, yes. And many of them are aware, but some of them are not able to control their eating behavior. And we do counsel them a lot, telling them whatever treatment in the world you take, ultimately you have to control what you put inside
into the mouth.
And so they do listen, of course,
they
small
listen,
percentage.
They listen in the office?
They listen in the office.
In the clinic. And then as soon as they go out? I'm joking.
That's anybody's guess.
So what is the most common eating behavior that is not bad for diabetes that you have seen?
Okay, so the portions of the carbs in India, I don't know about the rest of the world, but in India, more commonly they are not satisfied if their stomach is full. So they are not. They say
no, they are not satisfied. The stomach is empty. Half full.
Yeah, meaning they want to eat until their stomach is full. They want full stomach. They quote multiple reasons. I don't get sleep. I feel tired. I get irritable. All these things. So that is where they err, like a large volume of carbs during their meals, and they don't divide it through the day, and also they don't make it like a complex carbs. They don't really put much effort into. But people are changing. They are listening now with our stressing the importance of diet and the complex carbs. They are changing, but still quite a way to go. But they err on the volume of carb that they take. They're not prepared to give up on their favorite food, which is not good for diabetes. Not all of them. But the common problem which I encounter in practice is something like this.
Of course. I would encourage you to watch my video that I made on biryani. Okay. And I said, I went to a biryani shop and I said that, okay, this is whole biryani. This is so much amount of carbs and calories. I'm going to split it into half and then take the half tomorrow. And if you look at my subscriber base, half of the subscribers gone. The amount of carbs that we take is significantly high, even with the healthy carb portion. That was the key thing.
Correct. Yes.
So I do lifestyle medicine in the US, and there is a study called Masala study, where we focus dietary options in Southeast Asian community, and we focus on Indian community, and we have some Tamil patients as well, South Indian patients as well. If you take a South Indian meal, if they're eating healthy, so let's say rajma, channa, and they don't eat anything ultra processed, nothing outside. Even with the homemade healthy food, the carbs average per day is around 250 to 300 grams. And in that study, what we figured out was insulin resistance people who are already having pre-diabetes or diabetes will not be able to handle more than 150, 160 grams of carbs. So I've been telling people that, that's a sweet spot. So, you don't have to go like really keto or no carb, something like that. You could have like a moderation. Let's talk about exercise and diabetes. I've seen all diabetic patients walking. If you have a magic wand, will you say walking is better or strength training is better?
I think both are important. Aerobics obviously are important. 30 to 45 minutes a day roughly will be a good aerobic exercise. But also muscle strengthening and resistance training also helps in glycemic control, they have found out. So that can be complementary, not supplementary, not just doing the weights alone and being happy with it.
One of the biggest question is intermittent fasting and diabetes. So as I said, I promote time-restricted feeding based on circadian rhythm. So we did research and we thought that, okay, whenever we did research and we found out that a single ray of sunlight can stimulate the circadian rhythm and stimulate all the digestive hormones, including insulin. So we studied the growth of insulin hormone in the body and we take slowly secreting in the morning, peaks around the afternoon and dies down in the evening. Once the sun sets, so that's why we have been promoting, don't eat very late at night because your body may not be tuned for this. This is a kind of intermittent fasting where we give the gut rest for at least 12 hours. So many people have asked me, so I'm a diabetic, can I follow this? So in my experience, if you're not on any insulin, if you're just controlled with medications or pre-diabetes, the insulin fluctuation is not that much. But when you are on insulin, you need to be careful with all these intermittent fasting techniques where the fluctuation might be like so much that the glucose level may drop down. Your take on that, your experience?
Again, the intermittent fasting I do support to some extent, but there are different kinds of intermittent fasting. So some are very vigorous, which I wouldn't advise. Some people don't eat anything for 24 hours and then the next day only they eat. That won't work for diabetics because they are on medications. And you did mention about insulin. Also the tablets which act by stimulating insulin release, predominant mechanism, they are also a bit dangerous to take when they are fasting too long. And that also has to be
What is the brand?
The sulfonylurea group of medications. The other ones which we popularly use now, the metformin and also SGLT2 inhibitors, they are all kind of insulin independent mechanisms, and they work well with this sort of plans.
So as a part of a complication discussion, I actually wanted to cite the example of Tyagaraja Bhagavatam. So, as you know, he's a legend. But he has a long-standing history of diabetes that you may not know. Okay, and he died at the time of death. He was blind. He could not see anything. And I strongly believe that diabetes have progressed to damage the retina. That might be the reason for the presentation. Has this happened in your experience, in your patients?
Yeah, some of them, yes. Because people don't really check their eyes as necessary. For diabetic patients, we recommend every yearly once checking of eyes by an ophthalmologist. This is frequently misunderstood. People just go to an optometrist, no disrespect to them, but they don't look at the retina. So they just do the reading and all those abilities and prescribe the glasses. So we have to educate them that it's not just about reading. Patients say, I'm able to read well, I don't have any problem in my vision, why should I get checked? We should tell them that it is important to check because the early retinal disease due to diabetes will be completely asymptomatic.
So retina is the behind the eyes.
Yes, behind that, like a screen in a cinema theater. It's behind the lens where the images are captured and sent to the brain. So this retina, in the initial stages of damage, we don't really
have any symptoms.
We don't have symptoms, and people think it is not really that important to check, and that is where we educate them that this should be explained to the patient.
So let's say that the vision gets blurry because of diabetes.
Yeah. So that area is blotchy and not able to see clearly in a part of the visual field. So then this can happen in the other eye in other areas, then finally rendering the patient totally blind. So this is a really serious condition. So it is important to check preemptively when they are having initial stages of retinopathy and deal with it appropriately, control the sugars. If necessary, the blood vessels should be dealt with laser, preventing them from bleeding, thereby preventing loss of vision. So all this can happen only if they go to the ophthalmologist as advised.
So I'm going to tell you 2 points. Number one, if you know anybody with diabetes, they should be checked by an ophthalmologist once a year to check the retina. Number two, I'm sorry, that's the second point. Okay, once a year, an ophthalmologist, not optometry. Remember that. Okay. Okay. Second is diabetes can also cause kidney problems. There is something called diabetic nephropathy. I have seen patients going into dialysis because diabetes is not controlled, kidneys are not working, so dialysis needs to be implemented. And the third thing is diabetic foot. Okay, diabetic foot is something is very common these days. I've seen people actually getting amputated, getting foot being amputated, fingers being removed. My heart goes out to them because all this happens because there's decreased blood supply to all these foot. Decreased blood supply to the foot because
and the toes.
On the toes because the blood vessels is being
clogged.
Clogged, correct?
Poor diabetic control makes the inner linings of the blood vessels inflamed to begin with. So diabetes itself is called as an inflammatory disorder. So that is why the blood vessels, the inner lining gets inflamed to begin with. Then they gather materials like a protein called fibrin, calcium, platelets, everything. They form a plaque. So this plaque is the thing which clogs the blood vessels. To begin with, it affects the small twigs in the toes, the smaller blood vessels, because they are narrow in a lumen. And then they can go on to affect the bigger blood vessels as well. They can affect the heart blood vessels, which are bigger in lumen, and the blood vessels to the brain, all these things. So it's generally all blood vessels practically can be affected, small or big.
Small or big, yeah. So for example, if somebody wants to make sure that I'm not getting diabetic foot, should they have to go to a neurologist to examine, whether they are losing the neurological sensation?
If they have symptom, then it's better to straight away go, not for the yearly annual checkup. If they don't have symptom also, we have included in our diabetic packages to do this microfilament test, vibration sense testing, temperature testing, all these things nowadays.
Can you explain that microfilament test is you actually prick, correct?
It is like like a stiff animal hair like thing, like an elephant hair like thing. which you make a touch with slight pressure on the bottom of the foot and ask them whether they're able to feel the sensation well.
And you ask them to close their eyes.
And they close their eyes.
And you start picking and you will say, okay, right foot, left foot.
I'm able to feel. If it is felt less well, they also will tell us. That's microfilament test. And then with the tuning fork, we check the vibration. So if they have profound problem with the sensation, then we get a proper nerve conduction
study. But in general, it is better to have the study once a year, even if you don't have symptoms.
Yeah, exactly. That will bring out the early stages of neuropathy.
So we talked about all this, how do we diagnose, how do we treat, what will happen if you don't treat, and all those things. Now people are really interested in terms of how do we prevent diabetes to start with. We talked about lifestyle briefly, we're just going to go a little bit more about it. Being an endocrinologist, you always focus on dietary management a lot. If there is a patient coming to you with diabetes or even pre-diabetes, what are the 3 important dietary tips that you may say?
Okay, so I ask them to eat on time. And I ask them to make sure their diet is balanced.
With complex carbs?
With the complex. Mainly that is the stress point, is complex carbs is the main thing.
Example of complex carb that you like?
Okay, like it basically millet-based is quite popular in South India, to be honest.
So you Tinai, Ragi?
Tinai, Ragi, Kambu, Kudravali, these millets.
Right, foxtail.
Foxtail. So they are, because we use a lot of rice in our idli dosa batter, so they can supplement the idli rice with the millets.
What does millet do to insulin?
Okay, so millet is basically a low GI index carb, and so thereby it doesn't cause sugar to surge high. So in people who are insulin resistant and obese, it will prevent a further spike in insulin release, promoting further obesity, further increase in blood sugar. So that vicious cycle is set at a lower level, at least by this complex carbohydrates. And limiting the portion of the complex carbs, like 150 to 200 grams complex carbs a day. And that's what we,
that's what you recommend.
Tips that we normally tell them.
How do you include millet in your diet?
Okay. Yeah, we do. Actually, we do practice at our home. We are quite conscious as well. Though I don't completely replace idli rice with millets, at least 50-50%.
50-50.
We do that.
Your favorite dish? Millet-based dish.
Millet-based. Millet-based dosa tastes good, really, to be honest with you. But people think millet is less tasty. Not really. It's more crispy, and but you should eat it hot. In that case, I do like millet dosas very much.
You should come to US because somebody needs to save you his heart. All right, super. So the second thing is, whichever doctor I talk to, everybody is saying that stress is playing a role in their particular specialty. With this ever increasing stress in this environment, how does stress play a role in diabetes?
Yes, stress does play a role in diabetes. It pushes up the steroid levels in the body.
Cortisol.
Yeah, cortisol especially, and the counter-regulatory hormones, the glucagon and other adrenaline, everything goes up with stress levels, especially the cortisol, and that's not good for sugar. It raises the sugar levels.
Why does these hormones increase the glucose levels?
Mainly these steroids act by promoting the insulin resistance, and that's the way they increase the sugar levels. Even in hospitals, you may have observed somebody given steroid for asthma or autoimmune disorders, then the sugar goes through the roof. You have to jump around. So it quickly increases the insulin resistance. It also promotes this glucagon, pro-glucose hormone release as well.
And the body is thinking that, hey, you are stressed out, you need energy, you need carbs.
And it releases the glucose from the liver, which is the storage site for glucose.
And the stress can be anything, right? You are missing a deadline.
Yeah. Physical or mental?
Mental.
Yeah, it can be anything.
Have you seen patients taking insulin more in terms of the number of units when they are stressed out?
Yes, we do. Patients more commonly in family, there are feuds and problems happening in the family. They do tell them that something is going on, and their sugar levels significantly go up, and they come with the readings, and we do increase the medications and review their diet and stuff. Sometimes they may be eating out of stress. Stress eating is a problem.
So
all
you
these
have
things-
increased units in people
Yeah.
in that situation.
Yeah, so we advise them not to do that stress eating and then calming down with meditation and things like this. It's easy to advise, but we do recommend them to follow all these to reduce the stress
Reduce
levels.
stress levels, yeah.
It does make a difference. They typically come with note multiple sugar levels saying these 2 days it's high because of this problem happening in the family.
Wow.
So yeah, it is quite evident.
It's very directly correlation.
Almost, yeah. Yeah.
So you recommend meditation to your clients or
I do,
patients?
yeah, we do say. Many complain this. I don't get sleep. It's a very common complaint.
Is that because of diabetes or because of lifestyle?
A bit more of stress related. They do keep thinking when after going to bed about all their problems, trying to get a solution when they are at bedtime.
But I say,
I do advise them to some tips to overcome the situation.
So sleep is important to control diabetes.
Very important, yeah. Minimum 7 hours sleep a day, if possible 8 hours, but that would be luxury in today's world.
What does sleep do to control diabetes?
Okay, so indirectly the stress levels
Goes down.
So and then these stress released hormones
Cortisol, adrenergic hormones, adrenaline goes down.
goes down.
So glucose level requirement goes down.
Goes down, and as a result, if the insulin is being secreted too much because of this stress levels, that also goes down. So the insulin resistance goes down. Overall, the metabolically the patient improves and they feel fresh and refreshed. The next day, they are more positive and they are adhering to the advice given by us rather than being irritated due to lack of sleep.
One last question. Let's say that I forgot to mention, ask before. Let's say the eyes are damaged, kidneys are damaged, or foot is damaged. Is that reversible or is it irreversible?
In the early stages, it's reversible. For example, the urine thing I told about microalbumin. So if microalbuminuria is reversible if you control the diabetes and blood pressure also in a very tight manner, then it is reversible. But once it becomes more of protein leak in the urine, macroalbuminuria, then it's not really reversible.
Same thing with the eyes, no?
Same thing with not with the eyes though. Non-proliferative diabetic retinopathy is not really reversible. We can only slow down the progress or prevent them from getting the proliferative more worse situation. Neuropathy in the early stages, like nephropathy, can be reversible. Once established, it's difficult to reverse it. At least we can prevent further progression.
I remember that silent heart attack, silent myocardial infarction can happen in diabetes because they may not have any chest pain.
Yes.
Why does it happen?
The nerves which are damaged, the nerves are the ones which sense the pain and convey that to the brain. So once they have significant neuropathy due to diabetes, then they don't have the typical chest pain that they normally get with heart attacks. And they instead get other symptoms like some strange feeling in the hand or on the arms, left side. It can be right side also, not only left side, something going on inside the arm, or sometimes they may feel only breathless. Sometimes they may feel abnormally sweating, even in AC. They can be signs of a heart attack. There are many instances that they come only because they are sweating too much. They are brought to ER and you do the ECG, they have heart attacks.
Now, let's go to the common mistakes or maybe truth to it. I don't know, but I'm just going to ask you the common questions. One is, how do you place artificial sweeteners in your diabetic patients? What is the role?
Okay. I'm not really fond of these artificial sweeteners because the long-term safety of it is always in question. Periodically, there are reports sometimes saying it increases the risk of coronary artery disease. Some of them, not all of them. Sometimes there are reports that the malignancy risk goes up. Nothing is concrete and proved beyond doubt. But still, that's why I don't really advise because they are going to use it long term. We don't know really if it is.
So what I have practiced in my thing is that in gastroenterology it is very evident that artificial sweeteners damage the gut bacteria.
Right.
It's very clear. The lining is actually disturbed.
Right.
Even with a small dose of sucralose, small dose of erythritol, you name it. Okay, but whether that is being translated to any clinical outcome is the question. But what happens if you keeps on taking it every day for like 1 year, 2 years? The breakage becomes deeper, and that's where the complication happens. So what I have used, sir, is that some patients are very difficult to cut down on their dietary requirement without the artificial sweetness. So what I have said that, okay, you know what, you're trying hard, it's not happening. okay, why don't you take some sucralose or aspartame for like a month or two, so that your calorie requirement goes down with your sugar consumption. I'll tell you, my friend drinks 6 cups of coffee, and in US, if you see, there are like packets of sugar right next to the coffee, and they just tear it apart like 3 to 6 packets. Each sugar is three. You'll be saying, you'll be surprised, but it's very common practice. It's very common practice. So I say that, okay, in that case scenario, if stevia or Splenda or sucralose or whatever it is,
For a short time.
for short term, then you will adjust to the lifestyle change, and you will see the results.
Yeah.
Then that'll motivate you. Then you go back to your filter coffee with actual sugar with less amount.
Yeah, yeah. And I also stress the point that once you are used to this lower quarter teaspoon sugar, or if you put 2 teaspoons, you will keep the cup away. You won't be liking to drink it, which is true. Right? And then many of them do follow.
Nice. Brown sugar versus white sugar.
I don't think there is any big difference in them. They're all glucose at the end of the day.
So many brown sugar restaurants throughout.
Karupati sugar.
All right, sir. A software engineer who's very stressed out, he is relieving the stress by drinking alcohol. Social drinking, will that have any effect on diabetes?
Yeah, drinking every day wouldn't amount to anyway, as we know, social drinking. Like drinking once in a while in functions or get-togethers shouldn't be harmful as long as they keep their limits. And that should be okay as long as
for
they don't
diabetes.
cross the diabetic patients.
For diabetic patients. In general, what they say is that any sip of alcohol damages your gut bacteria, is bad for you, so prefer not to do. That's what the general thing is.
Okay.
But what people say here is that, okay.
But if we say so, will they
listen
to that? That is the listen to that is the thing.
So my idea is that, okay, you go very strong. Maybe they will do a little bit moderation. That's what the idea is. Yes, in my practice.
Okay.
But if we say that, it is okay to do this much amount of thing,
then they'll go
in more. Because multiple studies have shown that even like a one sip of alcohol is damaging your liver, damaging gut. It may not translate to fatty liver right away, but there is a risk involved. So all my patients, I say no alcohol.
Yeah, always. No alcohol is the best thing. But if somebody wants to drink, then what we can allow is this.
That safe limits.
Like social get-togethers and drinking very moderately can be okay. But if that can be avoided, that's the best.
That's the best thing. Yeah. Another controversial question for you. I'm going to say three things, okay? And you tell me whether it is good for diabetes. Hibiscus tea, Karela juice, fenugreek seeds.
Okay, so they are all not allopathic things, I believe. So generally, I don't advise patients on these non-allopathic kind of treatment for diabetes. I just tell them if you want to continue these fenugreek and Karela juice, they are not harmful or anything like that from the diabetes point of view. And if you want to continue, it's up to you. That's what I tell them to have their own take on it. But I don't advise myself because I'm an allopathic doctor, so it doesn't play a role in allopathic medicine.
Yeah. So in the US, it is not a big problem, but in India, there are other alternative treatment options widely available. When a patient comes to you with, I'm taking metformin, I'm taking insulin, but I also take other alternative medicine treatment options like Siddha, Homeo, Ayurveda, will you worry about the drug-drug interactions?
I generally tell them you have to follow one type of medicine, allopathy or Ayurvedic, whichever you want to follow. But please, I tell them to please make up your mind and don't mix the two.
Wonderful, wonderful education. So I'm just going to take you to some social media references. Okay. So I'm going to quote this, and I want you to say who said this. Okay. It's a very, very popular personality. So the quote is, diabetes is not just a disease, it is a lifestyle disorder. If we change our habits today, we can save generations from this suffering. Name who quoted this.
I'm not sure really. I'm not very active in social media.
So this is a movie person. This is a quote from Legend movie. Okay. This movie is being acted by Saravana Store's Anachi. And it's a reasonably hit movie actually. The music and everything was good. But in that movie, he was a scientist. And then he used to fight against the villain for creating gene therapy for diabetes. And all these villains would be like, oh, they will damage the lab and they will do all these evil things, and then finally he wins.
Right.
Any thoughts on gene therapy for diabetes?
The research is going on for gene therapy, especially the focus is on type 1 diabetes treatment. It's still in the research stage yet. Some different types of gene therapy experiments are going on, mainly for type 1. When gene therapy can be there for other problems as well, but now the focus is on type 1 because it's a autoimmune genetic-based disease. It comes due to alteration in the genes.
The chromosome 6 you talked about.
So it makes sense to focus on it. That's where some gene therapies alter the whole genome, the appearance or the structure of the genome that will be passed on to the next generation.
Very good job. So you get Saravana's to Katapai. We will give it to you.
Thank you.
Okay. And we're going to show you some reels, and then I wanted to get your input on that. Okay, sir. This is it's an insulin leaf, sir. So they're saying that this insulin leaf will actually decrease the sugar levels. And they say this is from Himachal Pradesh, and it's very popular. Will this fall into the category of this alternative treatment options that you will stay away from?
Yeah, I will stay away from this because I don't know about this. Basically, that is the reason. Thank you.
Thank you so much for a wonderful conversation, sir. You have been super. Thank you so much.
Thank you, Dr. Pal.
Thank you so much. Thank you. That was a wonderful episode. I liked it, but I'm really not sure whether you like it, this kind of conversation. You think it is too technical or it is too advanced. My goal is to give you medical information combined with some kind of humor so that it can be delivered easily. But these kind of topics can go really beyond some layman understanding. So please help me out in writing down in the comment section in terms of which part of the podcast worked, which part of the podcast did not work, so that we can learn from you and then give you some more good quality content moving forward, because the plan is to interview a lot of other doctors so that patients can get benefit out of it. So I'll be really, really interested to get your opinion. Remember, one belly at a time. It is absolutely important. Stay happy, stay gutsy. May God bless you.